If you can see it, we can restart. Okay. It's really my great pleasure now to introduce the next speaker, who is Professor Xiaochun Chen, who is president of the Fujian Medical University and also vice president of neurology section and geriatric section, the Chinese Medical Doctor Association, president of the Fujian Medical Doctor Association, and a neurologist with a very great interest in the area of Alzheimer disease. And so it's a great pleasure now to listen to you. And the title is Strategy to Facing the Challenge of Alzheimer Disease, a very big challenge that see all of us deeply involved. Professor Chen.
Thank you so much. Thank you, Prada Foundation, for your invitation. And thank you, Professor Comi and Professor Fudan, for your invitation. Sorry, I did not prepare the meeting in a thorough way, so I thought it's an event for the public education. And after I arrived, I almost noticed that this is a high-end, event with a lot of in-depth, profound discussion. So I'm sorry I did not prepare my slides in Chinese. I did not prepare my slide in English. Sorry if I not so correct. Please let me know. In China, Alzheimer's disease is a very severe disease for China, for the elderly population. So among the dementia population in China, Alzheimer's disease prevalence is very high. In the Western countries, there are a lot of controls and prevention for the risky factors. So there is a trend of decreasing prevalence. However, with the aging society of China and its acceleration, according to the surveillance, so we have found more than the 260 million people in China who are in the elderly stage. And among the elderly population beyond 60, the Alzheimer's disease prevalence is 3.9%, and the prevalence is on the rise as age. So that means it looks that we have 9.8 million Alzheimer's disease patients in China. So for a country which just eliminated the poverty, the Alzheimer's disease is a big burden on the economy and on the health of the people. And also we have about 38 million people with an MCI. So 29.5% of them actually are in the prodromal stage, AD. In other words, the AD-driven MCI. So the total number is about 12 million. So this number is much lower than the epidemiologics in the Western countries. So for the Western countries, so you can see that in the Western countries, about 40 to 50% of the MCI actually are driven by AD, but now our data is much lower. However, there is some accuracy issue. There may be a kind of underestimation or underdiagnosis. So that's why AD is a very big challenge in the public health of China, and this is the biggest challenge facing the economic growth. So according to our preliminary estimation, so the treatment cost treatment cost for AD patient is at least 120,000. And if you put other costs into consideration, like nursing and other cares for the patient, they may spend about 300,000 RMB a year. So that's why this is a very big challenge. I think that apart from the contagious disease, Alzheimer's disease constitutes one of the biggest challenges in the non-contagious area. So what we want to do is to pursue more control and prevention strategies in order to control the speed of acceleration, to try to improve the health of physical and mental health of the elderly people. So we have a special committee. We have a special committee for the dementia and cognitive impairment. It's just like the other Alzheimer's disease society in other countries. So we have that special group in China. So we cooperate with the state government and try to improve the prevention and control. So we have a low diagnosis rate, low treatment rate, and we have a shortage of the specialists treating their dementia. So we have about 100,000 neurologists in China, but no more than 3,000 are specialized in dementia. So you can see that if you ask the 3,000 neurologists to treat so many patients, that's a big burden. It's a big challenge. So that's why we try to establish a system, a hierarchy system of 3 layers. Our society cooperate with the government and then come up with some white book on the standardized establishment of diagnosis and treatment center of the cognitive impairment diseases. So we have 2 for Beijing, Shanghai, and Guangzhou, and in every province there will be a central or the senior center for treating the cognitive impairment. And also we have the region center or the county level center. So hopefully through this kind of 3 layers, 3 tiers of the centers, we can have very good life cycle management for the patient. And also through the different layers or tiers of the treatment and diagnosis, we can improve the referral, the bidirectional referral between the different tiers. So the day after tomorrow, the government will go to Xiaochun to issue the certificate to the different centers of AD diagnosis and the treatment, and we're going to further improve the training for the specialists and the primary care physicians. And now let's talk about the cohort in the community, cohort study in the community. So these are the famous community-based cohorts. A lot of cohorts in the world. So the most famous one is Framingham cohort study, and we have the cohort in Holland and the cohort in UK. However, in China, we don't have a mechanism from top to the bottom, kind of a standardized cohort study mechanism. So that's why 8 centers had the cooperation, launched the cooperation, and start to run the cohort study for the dementia patients in the community. So this is a project receiving huge grant from the government. So there are a couple of key issues. We want to understand the natural history of the cognitive impairment and aging in the community, and we're going to understand what are the impacting factors to influence the early conversion of AD, and how to have early diagnosis, treatment, and control for AD in the community. So there are 12 risk factors for AD, including in the elderly stage, middle-aged stage, and even in the adolescent stage. So we know that low education is the most important factor. For the elderly, it includes the diabetes, hypertension, tumor brain injury, and smoking, obesity, etc. And in the elderly stage, you know that we have the lack of activity, and also the withdrawal from the social activities. And recently, we identified that the eye diseases and also the sleep disorder actually are the additional two factors. So if you add those factors together, you will have 12 risk factors. So that's why our study would like to focus on those 12 important risk factors to find out the most influential factors contributing to the development of AD, and also to prevent the common Alzheimer's disease from progression into true dementia. So for patients without genetic factors, it looks that these factors contribute to 40%. So that means for the elderly people beyond 85 years who have a cognitive impairment, we can actually control the disease by controlling the risk factors, so that we can prevent the elderly people from progressing into dementia within the period of survival, or within their life expectancy. We found that those kind of patients are actually preventable if you can control the risk factors. And now with the AD precise treatment concept, we believe that the early diagnosis is a very important precondition. So if you have a look at the diagnostic criteria or framework, it looks that the biomarker is regarded as a very key important point. So it includes the radiological examination, CSF examination, and the biologics. You can see that we have structural radiology factors and also the biological or metabolic biomarkers. So we have such a big population. If we send everybody to MRI, if we send all the patients or all the suspicious patients for the A-beta testing, this is a big burden. And we don't have the resource to cover such a huge population. We don't have that resource if we run MRI screening or A-beta screening. So recently, we have realized that maybe we can do something like laboratory workup for the peripheral blood. So you can see that the CSF testing and PET testing have become the golden standard for the Alzheimer's disease diagnosis. And we know that if you are going to prescribe the anti-A-beta molecular antibody, you have to do the testing. And also you can do the A-beta PET or tau PET. However, the tracer is not commercially available in China for a beta PET or tau PET. Most of the centers are doing the testing within the scope of a clinical trial, so very much limited. So this is a problem, a kind of a bottleneck to restrict the accuracy of the AD's diagnosis in China. And recently, we are very keen on, doing the exploration for the peripheral blood biomarkers. I think that apart from the scoring system, questionnaires, the peripheral blood biomarker is an essential measure to improve the screening for the AD patients. So we can find out some of the suspicious cases, and then we can send them for PET, or we can send them for the lumbar puncture and do the CSF testing. So the blood biomarker can predict the deposition of A beta in the brain, and also, in particular, we can predict the conversion from AD-MCI to a true AD. And also, it can provide a very good diagnostic role. For example, it plays a very important role in the differential diagnosis. So in the Chinese consensus for China, it is recommended that we can use the blood biomarker or the digital cognitive measurement tools. We can do this kind of screening for the elderly population or in the adolescent population with the risk factors. And then if we find a red flag, we can send the people to do a CSF testing or PET. So there are a lot of manufacturers in China which can provide a diagnostic reagent kit for the AD, the blood biomarkers, but no one has been approved by the regulator. So that's also a limitation in the clinical application. I think that there are a lot of technical bottlenecks in the blood biomarkers. Now we have found electrofluorescence, and also we have found the other technique platforms, so that with those kind of technical advancement, we can do a better testing based on the blood samples, so that we can find out, a very good convenience when it is in the clinical practice. So that's why, our center is cooperating with many the manufacturers to try to pinpoint which is the best cutoff for the blood biomarkers. And there are also some international studies showing that by doing the blood biomarker testing, we can reduce the time to diagnose to about 10 months. So now we can use the blood biomarker to facilitate our diagnosis period. So finally, I'd like to talk about the precise treatment for Alzheimer's disease. And I'd like to showcase our recent studies. So firstly, you need to have a precise diagnosis in order to have a precise treatment. So before, we have to wait for the patient entering into the dementia, and it's a kind of exclusive diagnosis. That is, you have to rule out other diagnoses in order to put the patient into the group of Alzheimer's disease. But now with the biomarkers, we can have a better, precise diagnosis. So just like multiple sclerosis, in the AD area, we come up with the idea of DMT, or the disease-modifying therapy. So this is kind of a terminology which has been recognized by the international societies. So you can see that there are a lot of the DMT clinical trials, in particular anti-A beta or anti tau protein. So I think that most of the studies are focusing on A beta, and most of the studies are in phase 3, and also plasticity, and also the inflammation. These are also hot topics. I'm going to show you some of our studies showing the relation between AD and inflammation of the nerves. So this is a slide showing the pipeline of the anti-AD treatment.
Immunotherapies targeting A beta, internationally speaking, after around 20 years of development, finally, last year, we had a new therapy being approved, which is the aducanumab. It's been approved, and for aducanumab, we have ENGAGE and IMAGE, two parallel studies. For the two studies, the primary endpoint result are not aligned, so there's a lot of challenging questions about the study results. So later, FDA actually granted a conditional approval for aducanumab, and also had some changes about the indication of aducanumab as well. So far for aducanumab, it hasn't been approved by EMA or Japanese authority, but in China we are also thinking about using aducanumab. And last week, in our society, we have thought about the ENGAGE and IMAGE enrollment criteria, and we have did some of our exploration. We tried to enroll several patients already. And another good news is in January of this year, FDA also approved the lecanemab, co-developed by Eisai and Belgium. So we can see that for lecanemab, they are targeting the two factors that has very high neurotoxicity, and with lecanemab will be able to clear the protofiber and also the oligopolymer as well. So in the clinical dementia evaluation criteria, we can see that after 18 months of lecanemab treatment, for mild patient, we see significant improvement. We have around 27% of improvement. For CDR-SB, we can see there's a 0.45 delay of progression. For AD doctors, this is already very remarkable data, because if patients just have mild cognitive disorder, then CDI-SB is around 0.5 to 4. And for the natural development, basically, patients will gain 1 point every year. And if we can delay 0.45, then this means that 18 months of treatment can delay 5 to 6 months of the disease progression. So if it's working in the long run, then basically, for patients who are receiving this treatment, they probably will never develop severe dementia, so they can still maintain autonomy and also capabilities of everyday living. So it's very promising. I believe this is a milestone therapy. And also, as clinicians, we've paid a lot of attention to lecanemab. However, it hasn't been approved in China so far. So for the experts from our society, we are also working with Eisai right now. In the Eisai study for lecanemab, we have actually contributed several Chinese subjects as well. So we have officially submitted the registration dossier. We hope that maybe we can consider using lecanemab in some specific circumstances. I believe that would be a good news for Chinese patients. And for the monoclonal antibodies targeting A beta, we had a lot of study going on, and only aducanumab and lecanemab received good results. So for aducanumab, we can see so far in terms of clinical application, the result is not very promising. So for aducanumab, the manufacturer is not really investing in promoting this therapy. So for donanemab, we have had part of the phase 3 study results being released. So basically for donanemab, there might be some possibilities or promising roles for donanemab. And if we can take a look at the other therapies targeting tau, we only have one of them, the HMTM. This is the only therapy targeting tau that is still considering or conducting phase 3 trial for pathological tau and its association with the clinical signs and symptoms of AD patients. The association is actually stronger than A beta. So we are focusing on the therapies targeting tau. We hope that if we have future therapies, this can help improve patient symptoms. Since in clinical studies, we have had a lot of explorations, we had a lot of challenges, and a lot of failures actually. In the past 20 years, after a very difficult 20 years, maybe for AD, in terms of the pathogenesis, we need to reevaluate that. And for the target of the treatment, maybe we can re-explore the treatment target as well. So together with Professor Fudan's team, we had some cooperation and trying to explore the role of neuroinflammation in AD patients. So the peripheral systemic inflammation may drive neuroinflammation and accelerate the pathological progression of AD patients. And this is closely related to the brain function disorder of AD patients. For innate immunity and acquired immunity, we can see both are playing very important role in the pathological progression of AD. Previously, we focused only on neutrophil and also the myeloid cells, etc. Existing data demonstrated that lymphocyte actually play a very important role in the pathogenesis of AD as well. So how will the peripheral immunological response drive the neuroinflammation change for AD and the pathological progression of A beta? This is the study focus right now. Whether it's the microglia cells that is playing a role, or the monocyte and neutrophil that is playing a role, or maybe the lymphocyte that is playing a major role. Maybe it's T cell and B cell, these two peripheral lymphocytes that is playing a role. In this year alone, actually, we have a lot of the articles being published exploring the role of B cell in AD pathogenesis. And this is our study. We also focused on B cell for AD patients. In the transgenic mouse model, we can see that in the skull and also femur, as well as the other bones, ilion and lumbar, we have seen A beta accumulation. In the bone marrow, we can see that most of them are accumulated not in the long bone, but in more flat bones. And after the study, we've noticed that for A beta accumulation in the bones, we have done single cell sequencing, and we've noticed that that it's dominated by B cell clone increase. And apart from different size of precursor B cells, different types of precursor B cells are increasing. There is a special type of B cell which is called ABC cell that is increasing significantly. And also we have used the bone marrow tracing, and this has demonstrated that in the brain, the B cells and ABC cells are from the femur bone marrow. And now, let's come back to the cytokines in the bone marrow. For major cytokines in the bone marrow, we have done some examination, and we've noticed that IL-6 increase is quite significant. And IL-6, especially in ABC cell signaling pathway, the scoring for IL-6 is the highest. And if we inject A beta in the bone, intracranially injection, then we will also see A beta increase. So this has demonstrated that not only in the bone marrow we have the hematopoietic stem cell increasing, and also we have the ABC increasing and IL-6 positive cell increasing. Also, for ABC cells, we have done the injection in the ventricular of the brain. So in intraventricular injection, we've noticed that it's indeed quite related to the activation of microglia. And since we've mentioned that IL-6 will be able to promote the B cell infiltration in CNS, then maybe we can have a anti-IL-6 monoclonal antibody, tocilizumab, to treat these mouses. And we've noticed that with tocilizumab treatment, we've noticed significant reduction of B cell, and also in terms of the activation of microglia, it's been significantly reduced. A beta accumulation has been significantly reduced after tocilizumab as well. So actually, this article hasn't been submitted. We are preparing a manuscript, and we will probably submit this month. So comparing to previous international studies, we've noticed that the lymphocyte may play a role in AD pathogenesis, and we focused more on T lymphocyte. We believe that B lymphocyte actually is also playing a major role apart from T lymphocyte. So by proposing this new concept, we hope we can open a new possibility for AD management, so that we can have more effective and precise treatment of Alzheimer's disease. With that, I've finished my sharing. Thank you very much.
Thank you so much, I think, for this overview of the present and with some look to the future, which is, I think, extremely interesting. Now open to the question. Just to start, the B cells are becoming key players everywhere in some way. So do you think that this type of strategy need to be applied also in a very early phase? I mean, if you try to target also B cells, it could be a way to target very early in the preclinical phase, or do you think that it may extend even a bit more in terms of already clinically relevant disease?
An excellent question. About B cell therapy, right now we are still doing clinical trials, so we are still in the stage of clinical trials. And actually more in the animal study period. We are thinking about maybe we can register for the clinical trials of tocilizumab in AD. But what about the time window? Because not all AD patients may have B cell involvement or impact, or the intracranial B cell infiltration may not be the major mechanism for every AD patient. It could be just for part of the AD patients. So how can we better identify these patients with B cell activation? And then we can provide targeted therapy for these patients alone. So in clinical practice, of course, we want to publish this article first, and then we will register for a clinical trial and pass the EC. Ethics committee can be very difficult to pass because we are having a brand new concept. So this could be a very challenging work. We are doing some of the planning. I don't know whether this really answers Professor Comi's question. Probably not an excellent answer, but I think we need to really identify the time window. It could be a really narrow time window. And right now we're trying to establish of peripheral blood or bone marrow exploration to maybe do some of the bone marrow biopsy to confirm B cell activation. And in CNS, we are also trying to explore biomarker for B cell activation, maybe using A beta PET to reflect that there is indeed CNS B cell infiltration. Because microglia cell, we can already use A beta PET imaging or PET imaging to measure that. But for B cell, especially ABC cell PET image, it's still very difficult. We're still in experimental phase. So far with these two difficult technical issues, we're still a long way to go from clinical trial to clinical practice.
那个 ABC
For ABC cell, is that antigen presenting B cell? It's agent associated B cell. Okay, so for clonal expansion that you have seen, is that mostly in the ABC cell?
when you look at BCR, there's a clonal expansion. Is it enriched in the ABC cell type?
这个
ABC cell, usually we think it's related to the immunoinflammation in the CNS system. This is the cell that is playing a major role. So if there's a CNS infiltration, then this demonstrates there's inflammation in the CNS. So we've noticed that fully relevant interleukins, we have tested for several. IL-6 has a significant increase
Into the central nervous system, right?
我们是认为说它可能是有驱。
We think there is a driven effect, maybe via the signaling pathway, A beta via IL-6, because after intervention, we have seen reduced B cell infiltration, reduced ABC cells. So maybe it's via the IL-6 pathway. The IL-6 pathway is driven the ABC cells entering into the CNS. And for ABC cell, what are the known mechanism?
Its function.
它仅仅是 A B 细胞，就是他们做免疫的，应该是淋。
So for ABC cell, in terms of lymphocyte categorization, among B cells, this is a special type of B cell related to inflammation, closely related to inflammation. So would it induce inflammation or recruit by inflammation? It's involved in the inflammation process directly. Right, Professor Shi? We have the expert here. Let me try to answer. So in 2021, we have a paper published in Nature. And for normal brain, healthy brain, we compared brain of people under age of 18 and also brain above the age of 80. So we have compared anti-healthy brains. People die of a car accident, and we evaluated these healthy brains. Inside these brains, we've noticed that there is an environment in the brain that can support these cells to exist, or there is a possibility of in situ proliferation. I don't think this can really answer your question. So ABCs may be recruited from the peripheral, but also it could be in situ proliferated, but it could be originated from the peripheral.
Maintain this cell. This is what our Nature neuroscience paper showed. 就是衰老的脑内可能有
So for the aging brains, for the healthy aging brains, there might be a mechanism that can maintain in situ proliferation of these ABC cells, and that might have adverse impact on the development of the nerves. I have some following questions. For cohort construction, obviously that's very important. Professor Jia had a sporadic and also genetic family cohort, and in Chongqing we have another cohort as well. Professor Shi in Anhui is trying to establish a data as well, a cohort as well. From society-wise, association-wise, can we integrate these cohorts so that we can better collect the data? And since there's a lot of workload involved in data collection, so any plans? For the cohort that we are preparing this time, we have 8 institutions participated in cohort construction. They're from different parts of China, northern, southern, middle, and also western part of China. For northern part of China, we have Beijing Normal University. Professor Zhang from Beijing Normal University, he's taking the lead for Beijing cohort. And in the eastern part of China, Professor Jin's cohort in Taizhou will be our Eastern China cohort. In the southern part, Professor Ye is taking the lead in terms of our community cohort in the south. We have a sub-cohort of Brain Health from his team, and Professor Zheng Yan from Wuhan Technology University will be our western cohort. So they are highly representative. However, right now in China, I believe we are only missing Professor Zhi and Professor Du's cohort.
So these two cohorts are relatively independent. One of the cohort is involved in an international study, so their data is not incorporated. But otherwise, the 5 cohorts, are put on the same platform. For example, the data collection format and also the demographics, the blood biomarkers, and all the data formats are standardized between the 5 cohorts in the different centers. And also we have 2 laboratories. The first is Huada Jian, running the whole genome testing, sequencing. So Huada Jian is doing the gene testing, and radiology is handled by the a company under the Peking University. So all the radiology, core lab measurement actually is done by that core lab. So that's why we had a very good planning between the different cohorts, because we are on the same platform. And then if the platform is standardized, the data will be more persuasive. And also, we like to talk more about ABC cell. So we use the tracer to find that the ABC cell infiltrates from the cranial bone. So we try to use the tracer to find out where it comes from. And it's not from the peripheral, it's from the cranial bone. The ABC, the aging-associated B cell, come from the cranial bone. So I think that this is a very meaningful finding. So the significance is that if the disease is not controlled well, you can see A beta.
Yeah, a bit in this area of discussion. Can you anticipate where are these B cells located? Are there more parenchymal cells, or are there in the subarachnoidal space?
Based on our study, in the end, ABC well concentrated in the cognition-associated areas like hippocampus. You can find a lot of the ABC over there. And also, we can see that in the frontal cortex, you can see the ABC.
Good.
Just last question. 最后一个问题就是我然后
So I think this is the last question. Thank you so much for your effort that you do the biomarker to trace the A beta or the Alzheimer's disease. I think that this is more feasible than such thing like A beta PET. I believe that from the point of view of registration, you need about 5 to 10 years to get approved. And in this period of time, you need to do the prospective study to identify the relativity and to accumulate the international experience. It's a very great effort under your leadership. I think that it looks that China can do something from this regard. And we established a reference range for the tau and the A beta in the Chinese population because the cutoff value varies across the different age groups. So we need to understand the specific level for the detail for the different age groups. And we know that the liver function and kidney function will make an impact on the level of the blood biomarkers. So in this situation, would you consider a different reference range when there is a concomitant disease? I think that standardization is very important. This is my suggestion. Thank you. So we know that peripheral A beta is impacted by the concomitant diseases. However, Beta 1A1 and the Beta 187 is pretty stable. And also we can refer to the genetic testing, and also we can refer to the digitalized cognition evaluation to do the modeling. So by the modeling, it looks that if we combine the three testing, we can make it more accurate. We have a lot of articles published. Thank you. All right. I think that the next talk is also associated with some, one element or one molecular which is associated with the Parkinson's disease. The next speaker will be Professor Wang Jian from Huashan Hospital. Please, Professor Wang Jian.
Professor Shi, and all the distinguished guests and all my colleagues. It's my great honor to be invited by the organizer to attend this activity. Today, my topic will focus on tau imaging in Parkinsonian disorders. Shanghai actually entered is the first city in China of entering aging society. So, how to deal the aging-related neurodegeneration right now is not only a medical issue, but also a headache for the whole society. In terms of the neurological disorders, it's been considered as a continuum or spectrum from the left end ALS to the right end CJD. In the middle, there's a couple of the neurodegenerative disorders, including FTD and the multiple subtyping. AD, PSP, CBD, DLB, PDD, and PD. From different level of the perspective, there's a couple of the major players involved in the different perspective: protein level, gene level, pathology level, and there's a lot of overlapping between each other. Today, I will focus on Parkinsonian disorders. It's not just Parkinson's disease, but also a typical Parkinsonism, including PSP, CBD, MAP gene, genetic mutation-related neurodegeneration. Definitely, AD is the most prevalent neurodegenerative disorder in this field. And it attracts a lot of attention and efforts during the past decades. In pathology, the progression of A beta and tau propagated in a specific spatial and temporal pattern in a manner of the synergistic. So this fundamental basis for the AD pathology gives us a lot of insight to develop the biomarker-based diagnostic framework and eventually the disease-modifying therapy right now. Professor Chen just mentioned that. And also give us a lot of good example, the enlightening experience for other neurodegenerative disorders, including our PD and the PSP. PSP is another neurodegenerative disorders with some uniqueness. You know, it's relatively pure to tauopathy with a typical Parkinsonism. You know, compared with AD, with CBS, there's mixed pathology in AD, in CBS, but PSP is relatively pure. You know, from this perspective, relatively pure tauopathy give us a good starting point to study the imaging, molecular imaging, and disease-modifying therapy. With the advance of the technology in terms of the structural biology and cryo-EM, tauopathy can be categorized into more subgroups, not just 3R, 4R, the mixed 3R and the 4R. From their perspective, they can be categorized into more subgroups. PSP is closer to GGT, and the CBD is closer to AGD, and AD is closer to CDE. Maybe each isoform of the tau is the fundamental basis of each tauopathy. From perspective of our clinician, I'm a neurologist. We love to look at these disorders from a straightforward perspective. How to visualize the pathological process of these disorders will give us a better insight to understand the etiology, the pathogenesis, help us to do a better job regarding the early diagnosis, the differentiate diagnosis, and also the measurement of the target engagement regarding the disease-modifying therapy. Among all these tracers, of course, A-beta is the leading position. At least several compound tracer has been approved by FDA regarding A-beta imaging. Tau follows closely. AV1451 has been approved by FDA to image tau in the patients with tauopathy. Alpha-synuclein tracer is just emerging on the horizon right now. I will elaborate that later. And TDP43 is the protein implicated in the pathogenesis of ALS. The tracer for imaging TDP43 is still lag behind. Okay, today my talk will focus on Parkinson's disease, Parkinsonian disorders, and using this tracer, a novel generation of the tracer, tau tracer. It's called flozolitol. It used to be called PMPBB3 and also APN 1607. Okay, firstly, PSP, progressive supranuclear palsy. You know, previously, AV1451, the tracer for imaging tau in Alzheimer's disease, has already been investigated in the area of PSP. But the affinity to tau in PSP patients was not good enough. You can see the affinity is relatively low. So for this tracer, you can see in the area of AD, the performance of the imaging pretty good, but in the area of the neurodegenerative Parkinsonism, you know, the difference between healthy control, PD, PSP, CBS is very little because of the poor performance of the affinity. Another first generation tau tracer, THK 5351. There's a concern for this tracer is the off-target to MAOB. The previous version of the APN 1607 is PBB3. You know, for this tracer, the signal to noise ratio is not good enough to have a good contrast. So that's the limitation for the tau tracer of the first generation. PI 2620 belong to the tau tracer of the next generation. You know, in AD, in the cortical area, you know, the uptake of this tracer is consistent with the tau pathology in those patients. And in the patients with PSP, Richardson typical subtyping and the non-Richardson subtyping. You know, in the disease-related region, in the basal ganglia, a pretty good signal observable over there. So PI 2620 is being considered as one of the most promising tracer in this area. The tracer we are using in our research work is this one, APN 1607. It was first reported by Japanese research team 2 years ago. From this paper, from the picture in this paper, you can see compared with the PBB3, the signal to noise ratio are pretty good, much better. And even in the subtyping of the PSP, Richardson typical, and the PSP-P subtyping, and PSP-FTD subtyping, there's corresponding the tracer uptake in the cortical or subcortical. In Richardson typical PSP, both the cortical and the subcortical involvement can be observable. That's the work we did 2 years ago. We also used APN 1607 as the tracer to image the patients with PSP with different subtyping, PSP-P subtyping, Parkinsonism, PGF, breathing gait, Richardson, and also we chose the other atypical Parkinsonism, MSAP, as the disease control, and the PD, alpha-synuclein per se, as the disease control. We also did the correlation between the clinical rating of the PSPRS and the uptake of the APN 1607. It's significantly correlated. So that means this tracer has the potential to evaluate the severity of the disease in an objective manner. Of course, it needs to be validated in the longitudinal study, which is underway right now. Since we also recruit the MSAP and the PD as the positive control, disease control in our group, so we are able to answer the question sensitivity and the specificity of this tracer. For example, in the STN target, the uptake of APN 1607 had a relatively pretty nice performance with AUC 0.94. The sensitivity and specificity in STN binding help us to do a good job in the differentiate diagnosis between PSP and MSA and the PD. Just recently, we published another paper expanding our sample size. 2 years ago, the paper we published in the movement disorder, the sample size for PSP only in 20s. But this time, more than 140s. So this way, we did a conditional probability analysis to answer a question whether or not this tracer, this tau tracer imaging, are able to capture the distribution pattern and the regional vulnerability of tau pathology in the patients with PSP. The answer is yes, of course, we need the longitudinal study to confirm the finding. It's still ongoing, but for this cross-sectional study, we can, right now we can draw this conclusion that it might be able to, this APN 1607 imaging are able to capture the distribution pattern. Regarding the disease-modifying therapy in PSP, another concern is whether or not those imaging, if those imaging served as the important secondary endpoint, is that confounded by the therapy? MLB inhibit selegiline. You know, it's a very common anti-Parkinsonism medication. Well, there's very limited sample size, only 3 cases with the longitudinal follow-up 1 year, not 1 year, just after the treatment of the selegiline. We did the APN 1607 tau imaging before the treatment and after the treatment. No observable change was found. So in other words, this tracer was not confounded by the MLB inhibit. So that's a good news for this tracer to monitoring the progression of the tau deposition in the future regarding the disease-modifying therapy. Okay, next one is the MAP gene mutation related neurodegeneration. It's a very rare neurodegeneration, but it gives us a very good opportunity to address the question. This tracer, you know, is specific for or has any specific affinity to 3R tau or 4R tau or mixed. Previously, AV1451, this tracer was also used to investigate in the MAP gene mutation carrier. Within the exon 10, the mutation within the exon 10, you know, that means that's 4R tau. Outside of the exon 10, that's not. So for this AV1451 tracer, for those, oh, sorry. You can see for those patients within the exon 10, a mutation located in within the exon 10, you know, the signal was pretty weak. So AV1451 is not a good tracer for imaging 4R tau tauopsy. Recently, we collected 7 cases with genetic mutation in 5 categories. And 6 patients of 7 carry the genetic mutation within exon 10. So that means they are the 4R tauopsy. The clinical manifestation for MAP genetic mutation related to neurodegeneration is pretty comprehensive, from PSP to Parkinsonism, FTD, and even CBS and ALS. We can find the tracer uptake in the cortical or subcortical region corresponding to their clinical manifestation. If we take a closer look at those 3 cases with longitudinal tau imaging, we can find the arrow indicating that over time, by the annual follow-up, the follow-up, not only the clinical rating, but also the imaging, the tau imaging, you can see the tau tracer uptake in the brain, in the disease-related region, increased substantially, but not for all 3 cases, only the first one and the third one. Maybe for the second one, 1 year follow-up is not enough to observe the change on the tau imaging. That's the quantification, the same interpretation indicating by the arrow. Okay. The third neurodegenerative disorders we investigate is CBS. CBS is not just CBD. CBS can comprise CBD, but some of the CBS has the pathology of AD pathology, even TDP-43. Not all CBS has the 4R tauopathy. Recently, we just, sorry, that's not the work of our team. That's published 2 years ago by other team using the PI2620, this tracer, to investigate the CBS. A-beta imaging was also performed for those cases. Interestingly, we found that, for those cases, for those cases with Alzheimer's disease, the pre or post-central gyri is spared from the tau tracer deposition. But for those cases with the CBS, also with the A-beta deposition, but this area is reached in tauopathy, in tau tracer uptake. So very, very interesting. That's the work we just did recently. We used this tracer, fluoroxolitol, APN1607. We found a similar pattern. You can see for this case with Alzheimer's disease, in the motor cortex, the tau uptake was spared. But for those cases with CBS, in the motor cortex, the tau trace uptake over there is very rich. And also, we got the chance to follow up 3 cases with CBS by using this tau imaging. Only 1 case showed the increased uptake, the expand area of the disease-related cortical region. That's the baseline. This is the 1 year after the baseline, the follow-up. But for the other two cases, we didn't observe the longitudinal tau tracer imaging change. PD is not a neurodegeneration with tau, as the dominant pathology. PD is alpha-synuclein per se. But for the patients with PDD, PD dementia, actually, there's a lot of co-pathology, including tau pathology and A-beta pathology. So that's also the target. That's also the subject of our investigation recently. Previously, 6 years ago, AV1451, this tracer was also used to investigate the tau imaging, tau deposition in PDD. Found in PDD and the DLB, tau trace uptake in the cortical area was significantly increased. Recently, we published a paper. We recruit 10 patients with PDD and 9 patients with PD, normal cognition, and 9 healthy control. We found the APN 1607, also called fluoroxolitol, the trace uptake in the cortical area is significantly increased compared with those PD with normal cognition. In the occipital cortical area, the tau tracer uptake, the quantification is correlated with the MMSE, the clinical rating. So that means for those patients with PDD, tau pathology play an important role for developing a cognition problem for those patients. Okay, that's the last part of my talk. What's the clinical value and future perspective for all this molecular imaging? Professor Chen just mentioned the antibody targeting tau failed in the area of AD. 2 years ago, they failed in the area of PSP either. 2 antibody targeting tau for those patients with PSP failed. There might be a lot of explanation for this failure, but in my opinion, the first explanation is without the biomarker-based diagnostic framework for the patient's inclusion in this clinical trial. The accuracy of the diagnosis is not good enough to run this kind of the clinical trial. The misdiagnosis rate is supposed to be pretty high. So you can see there's even no tendency of any efficacy. Okay, for patients with Parkinson's disease, that's the most prevalent neurodegeneration in our field. Last year, the antibody targeting alpha-synuclein, the clinical trial for prasinezumab, failed as well. There's some tendency of efficacy, so Roche company immediately run another clinical trial, optimized the clinical trial design and want to observe the positive outcome in the future. The limitation for running this clinical trial, there's a very obvious one. That is, no tracer for imaging alpha-synuclein in this clinical trial. That's number one, limitation discussed in that clinical trial. There's no target engagement measurement. Lecanemab, Professor Chen just mentioned as a breakthrough. Yes, it's not only breakthrough for AD, but also the breakthrough for the whole field of the neurodegeneration. I think during the past maybe 18 years, that might be the only milestone of the breakthrough in the field. In my opinion, one important reason is during the past 5 or 6 years, the biomarker-based diagnostic framework for AD, ATN system, was well established, was well applied in our research setting and our clinical setting. So that enabled that clinical trial to be successfully observed the positive outcome. That's ATN diagnostic framework. A means A beta, either PATE or CSF. T means tau, either tau tracer or CSF. And FDG itself is not specific enough, but regarding the metabolic network imaging, actually, it's kind of specific for Parkinson's disease. So it's also kind of specific. I will elaborate that later regarding our own research work. We are all wondering whether or not in the near future there will be a framework for PD diagnostic, just like ATN in AD. What's the thing we still lack? We already have dopamine transport imaging. It's pretty good. That's the work we published. By using dopamine transport imaging, it's essentially important for us to distinguish between neurodegenerative Parkinsonism and non-neurodegenerative Parkinsonism. And different Parkinsonism have different pattern. For this FTL-DMND Parkinsonism spectrum with TPK genetic mutation, you can see the dopamine transport reduction dominantly in the caudate instead of the putamen, dominantly, sorry. Okay, for the FDG metabolic network imaging, I just mentioned it can show some specificity and sensitivity by using AI technology to analyze the deep metabolic imaging in this. It can provide us, a good tool to differentiate the typical Parkinsonism, PSP-MSA, and the typical Parkinson disease, with pretty good accuracy. You can see this ROC looks pretty good. if we want to develop the ATN-like diagnostic framework system in our PD area, right now, what we really need is the imaging, is the biomarker imaging alpha-synuclein. Last year, 2 tracers targeting alpha-synuclein was reported for those patients with multiple system atrophy. Only 2 cases for this one, 3 cases for that one. This is the development by the European team, that's a Japanese team. So if one day those tracers targeting alpha-synuclein can be available, just like tau tracer available for imaging PSP or AD, that will be a very important component of developing the diagnostic, the biomarker-based diagnostic framework for our area, increasing our early diagnosis accuracy, better differentiate diagnosis, and also monitoring the progression of the disease. That's the effort we tried during the past 10 years. We worked together with Professor Cu in Fudan University to develop this tracer for imaging alpha-synuclein. It's still in early stage. In vitro data looks good regarding the affinity binding with alpha-synuclein and the good immunostaining data from the postmortem analysis. But we are still working on the imaging in those animal model with alpha-synuclein. And then, hopefully, eventually, we can move it forward to the clinical, to the patients. And recently, the advance in the structural biology and cryo-EM enable us to optimize the tracer by using their technology to study which domain, which kind of the trap is the good side for binding the tracer. Yeah, that's also the thing. That's not our publication. We are also working with the expert in that area to optimize our alpha-synuclein tracer development. Okay, that's the take-home message. Tau imaging is very helpful for us to diagnose the Parkinsonism with tauopsis, including the PSP, CBD, and MAP genetic mutation related neurodegeneration. Even though it's still at the early stage, but there's PI 2620 and APN 1607 available in the research setting, moving forward. Secondly, biomarker-based ATN diagnostic framework dramatically improved the accuracy of the AD diagnosis. It's a fundamental basis to successfully lead to disease-modifying therapy like lecanemab in AD area. So in our PD area, that dopamine transport is kind of equivalent to A beta for AD. You know, it's the prerequisite or precondition of diagnosing PD, but it alone is not enough to diagnose PD, just like A beta in AD. FDG, metabolic network imaging, is very helpful for us to do a better job in the differentiate diagnosis among PSP, MSA, and PD. So in the future, together with the relevant TOPS, tau imaging or alpha-synuclein imaging, which is already on the horizon, I think it will be very important, very valuable to develop a biomarker-based diagnostic framework and eventually leading the disease-modifying therapy for PD. So I understand it's a long way to go ahead. But it deserves our effort to pursue in this right direction. Okay, that's it. Finally, I would like to acknowledge my team and my collaborators, Professor Zuo Chuantao in PET Center, Huashan Hospital. Collaborate with my team for more than 20 years. And April Neuer, the provider of the APN 1607, that tau tracer for our team. Professor Jian and Mr. Zhang, and also Professor Kochi from QST Japan also give us a lot of professional advice in that regard. And also Professor Chu from Fudan University. We collaborate focusing on alpha-synuclein tracer development for more than 10 years. It's pretty challenging. And also appreciate the funding agency. Thank you. Thank you very much for your attention.
So, 问题评论.
Any questions?
It's a great talk. I have a question. So, does tau protein usually accumulated on the very position where the neurodegeneration happens, or is it likely that the tau protein is transported from the blood vessel and eventually accumulate in the basal ganglia, but a very particular degeneration happens in other places in the brain? Thank you.
Thank you. Thank you for your question. Actually, different neurodegenerative disorders has different origin of tauopathy. For AD, it starts from the temporal lobe, but for PSP, the starting point is the midbrain. I don't think they originate from peripheral issue, blood, and then transport to a brain. I don't think so. Yeah. So, based on the pathology, different neurodegenerative disorders have different origin. But why in PSP they originate from midbrain for those patients with AD from other area? It's complicated story. Yeah.
Oh, thank you very much for your inspiring talk. One problem with clinical trials in neurodegenerative diseases is like computerized training or rehabilitation that we arrive too late. Mm-hmm. But your tools, like in stroke, people understood that maybe it's not too late if there is a penumbra, like a tissue that is suffering from lack of blood, but it's still alive. So is it possible to use both metabolism and tau imaging to see whether there is a tissue that is affected by tau but still alive and functioning so that we can rescue?
Yeah, a pretty good question. Yes, the early diagnosis means the beta time window we can intervene, of course. For alpha-synuclein per se, including PD, MSA, maybe RBD, rapid eye movement behavior disorders, those kind of the prodromal clinical feature can give us a good time window to detect those with higher risk. So if we have the technology of alpha-synuclein tracer, maybe we can did the imaging of alpha-synuclein for those patients with prodromal stage. But for tau, actually for PSP, I don't know. I don't think we have any clinical close to detect those earlier stages. Of course, the earlier stage we can make the accurate diagnosis means the beta time window to intervene. But the balance is, the earlier stage means the more challenge you are facing to make the correct diagnosis. So how to make I don't know, the trade-off or compromise is a big issue we are all facing. Thank you.
因为我们超了20分钟，所以
We are 20 minutes later, so please keep your question short.
还有问题吗？
Any other questions?
Elaborate more. How can we apply cryo-EM to optimize the development of tracer? Because structure understanding or optimization, what aspect can you do that?
We collaborate with the expert in that field. By using the cryo-EM, they are able to identify which domain forming a specific trap.
Okay.
That trap is very specific for binding a tracer. If not that kind of the trap, actually the binding is not so specific.
All right.
So yeah, that's the technology will give us a lot of assistance.
Regarding the failure of the trial for tau monoclonal antibody therapy in AD, the assumption would be that because with many other proteins, beta amyloid, oligomer also deposits, but for PSP, it's almost exclusively caused by tau. Why? What's your perspective why the trial failed?
That's a good point. Actually, tau is the protein intracellularly. A beta is the extracellularly. So for alpha-synuclein, for tau, they are located in the intracellularly. So my point is the antibody is not the good strategy for those cases. Maybe small molecular compound have more chance. That's my opinion. Yeah.
All right. I think we have to close the session. Thank you very much for the very provocative presentation. So we close the session because we run a little bit late. So maybe we can return 像3点45可以吗？
So let's return by 3:45. Let's return by 3:45.
Yeah, 10 minutes. All right.